Move to the next talk. Invasive investigations in uveitis diagnosis would be given by Dr. Mudit Tyagi from LVPI Hyderabad. Dr. Mudit, please. Is the last talk.
Yeah, all right. So first of all, good morning and thanks to the chair of this session and AIOC for giving us a chance of talking on the role of investigative investigations or invasive investigations in uveitis. Now, when do we need them? When do we need biopsies? We need them in cases where sometimes we are not clear. So this was, let me give you one example. This was one patient who was seropositive for HIV, also was a known case of abdominal tuberculosis, came with an exudative RD. This patient was already on ATT, but in spite of that, the lesions were not responding. This lesion was persisting and the exudative RD was increasing. There was also scleritis in this patient. So these cases, these atypical dilemmas, these problems, these masquerades, these conundrums, these are the ones where invasive investigations can come to our rescue. So like I said, when do we actually need biopsies? We need them in these cases. So this was one more case. This was a patient who had multiple lobulated scleral abscesses, discontiguous lesions, and areas of resolved scleral abscess. But these patients came back with. We took a biopsy. We did a scleral deroofing initially, and then after you have done that, you can easily go ahead and take a biopsy from these areas. And this biopsy can then be sent for microbiology. This was the pus that we got over here from this patient. The sample can be easily taken and then subsequent for a biopsy because this was a case which was having multiple recurrences, had initially been actually treated on lines of drug resistant tuberculosis. But what happened was that when we sent it for biopsy, the scraping which was there, that revealed presence of septate fungal filaments which were positive. This was actually a case which was secondary to fungal infection over there. Started on antifungals and this patient did well. So like I said, cases of dilemmas when you do not get inadequate response to treatment, masquerades, endogenous endophthalmitis, these are scenarios where invasive investigations do come to our help. And what are the ones which we have at our disposal commonly? Taking a tap or a sample from the anterior chamber, vitreous biopsies, scleral deroofings, and if nothing else works, then a retinochoroidal biopsy in some of these cases. So this was one more case. This was a case which I had shown earlier in one of my other talks also. This was a patient who came with this blood-stained hypopion. When we took an AC tap as well as a peripheral blood smear, what we got was myelometacytes and metamyelocytes. And this was a patient who was a case of CML. So this was a blood dyscrasia where the AC tap as well as the peripheral smear revealed the presence of these band cells and these atypical cells, which helped us in diagnosing this to be a case of a CML rather than a uveitis over here. Another case, this was a lady who was a known case of non-Hodgkin's lymphoma, came with this retinitis lesion in the right eye and extensive vitritis and some retinitis lesion which could be seen underneath this. This patient had a complete remission and the last cycle of chemotherapy had occurred 2 years back. So now at this point of time, what are the differentials? It can either be an infection or it can be a lymphoma in this patient. So we took a biopsy which came positive for HSV as well as CMV, but was the cytology was negative for any lymphoma cells, and what we had was a reactive inflammatory infiltrate. So this was a patient which actually had a CMV retinitis, was treated with oral valganciclovir. The left eye was no PL to begin with, but we could salvage the vision in the right eye, which was maintained.